This is chapter 56, discussion of colorectal cancer. This is a nice slide, again, showing how your colon, you have your ascending going up the left side. You have 22% of colorectal cancers in that area. Your transverse colon across the top, 11%. Of course, your descending colon down your left-hand side, and at 6%, and then the majority of your colon cancers occur in your sigmoid and your rectal colon. So colorectal cancer refers to the colon and the rectum. Those two areas make up your large intestine. Most of your colorectal cancers are what we call adenocarcinomas, and those are tumors that come up from the glandular epithelial tissue of the colon. This is a multi-step process and cause a lot of other genes and certain oncogenes to be affected. Most colorectal cancers are thought to arise from patients who have polyps, and that's why having a colonoscopy and being checked after the age of 50 or after is so important, because polyps are a precursor to colorectal cancer and can be taken out at the time of having a colonoscopy. The etiology is age less than 50, age greater than 50, excuse me. Most people, you do not see really colorectal cancer under the age of 50. Of course, genetic predispositions, whether your family, you have a personal family history of cancer, and then there's a condition called FAP, or familiar adenomatous polyposis, and that is a family history of cancer, or FAP is a genetic disease, and patients can be tested for it, especially if they know that they have a family history, and it, I believe, is a blood test for that specific genetic process. Colorectal cancer is the third most common cause of death in the United States. Again, it is not common before age 40. African Americans are more at risk for colorectal cancer than Caucasians. People that can be more at risk are, again, those that smoke, who have a high-fat diet, um, people that drink, diets with large amounts of carbohydrates, diets that lack fiber, because the fiber does help decrease the amount of time the stool sits in the bowel. Want to teach people, about the hazard of smoking and physical inactivity. So the staging for colorectal cancer, there are 4 stages. The first stage is basically where the tumor invades up into the muscle layer. And realize that when you're talking about tumors for colon cancer, your tumor can spread anywhere into your system. It can spread locally just into the layers of the bowel wall. It can spread into surrounding organs. It can spread into the lumen of the bowel, of course, or the lymphatics, or the circulatory system. Spreading into the circulatory system or the lymph system is through blood, primarily. The liver is the most common site of metastasis from circulatory spread. You can also have metastasis to the lungs, brain, bones, and adrenal glands. Complications from the growth of tumors from metastasis can include bowel obstruction, which we'll talk about in a few minutes, or you can have perforations into other parts of the bowel with abscess formations and fistula formations. So that's why it's always important to have patients diagnosed properly, and the earlier they're diagnosed, the better their prognosis can be. Stage 2 can invade up into the other organs or perforate through the peritoneum. Stage 3 is any level of tumor invasion that involves the lymph nodes. And then, as with other most cancers, stage 4 involves metastasis to other sites of the body. So this slide shows colonoscopies, but before I get to that, just a couple of other things. There is a lot of active health promotion and maintenance that we can do with colorectal cancer. These patients need to start thinking about screening around the age of 40 to 50. Screening in the form of doing the fecal occult testing in the primary care's office. At 50, they need to be starting thinking about colonoscopies. With a colonoscopy every 5 to 10 years, people who have a personal history or a family history should be screened earlier and more frequently. Tell these patients to modify their diets, decrease fat, carbs. They need high fiber foods. Encourage baked or broiled foods. Basically, a good, healthy diet. When taking history from these patients, when you're looking at thinking about colon cancer, you need to ask if they've had any other cancers before, especially breast, ovarian, or endometrial cancer, because all of these can spread to the colon. Ulcerative colitis, Crohn's disease, FAP or adenomas can also lead to colorectal cancer. Ask about whether the patient again uses tobacco or alcohol, and then changes in their bowel habits such as constipation or a change in the shape of the stool with or without blood. Generally the first sign you will see with colon cancer is blood in the stool, specifically blood in the stool from the lower half, from the sigmoid and the rectal colon is where you generally will see this. They can also report fatigue, which is related to anemia. Anemia is another sign that you will see with colon cancer. Abdominal fullness, vague abdominal pain. They really don't know where it's coming from, and then unintentional weight loss. And a lot of these symptoms do go ahead and suggest advanced disease. But again, the most common signs are rectal bleeding and anemia, and then a change in the stool consistency or shape. So, with your colostomies, which a lot of times for patients who have colon cancer, the best thing that a physician can go in there and try to remove the tumor if it's in a place where they can remove it. A lot of times they will need to do a colostomy, either a temporary or a permanent colostomy while they're doing treatment. So the ascending colostomy is done for a right-sided tumor. The transverse colostomy is used a lot of times in emergencies, like intestinal obstructions, or where they really need to get something done quickly. The descending colostomy is done for left-sided tumors, and then the sigmoid colostomy is done for a rectal tumor. Colostomy care, you want to be looking at the normal appearance of the stoma. Remember, it should be beefy red. If it's gray or blue, then you're not getting a good blood supply. We need to be teaching these patients signs and symptoms of complications. The colostomy should start functioning in about 2 to 3 days post having it placed. Again, may need to be emptied frequently because of excess gas collection. As we're discussing signs and symptoms with our patient, we again want to let them know it's going to be, kind of a reddish pink. If it gets to be purplish or gray, then that needs to be reported to the physician. It needs to be kept clean and dry with a mild soap and water, specifically before putting on their stoma bag. Measurement of stoma. They only need to have a hole large enough to cover the skin around the stoma itself. The stoma will shrink about 6 to 8 weeks after surgery because you do have some swelling right after surgery, so it should be measured at least once a week during this time. And if the patient loses or gains a new weight, then it needs to be measured again. We're going to need to be teaching the patient and the caregiver, to trace the little pattern on the the board, and I'll try to remember to bring one of those to class. Um, have them look for signs and symptoms of infection. Uh, dependent upon where the stoma is placed, like in what whether it's ascending, transverse, or descending, will determine what the stool looks like, whether it is more formed or more loose. Appliance use, care application, appropriate appliance to cover stoma. Hopefully, all of this will be discussed in the hospital. A lot of hospitals have wound care and stoma nurses to help the patients learn how to put their appliances on. Measures to protect skin, again, keeping it clean and dry, washing it with a mild soap and water. Dietary measures to control gas and odor. Generally, foods you want to things that can cause phletus, of course, are your beans, broccoli, spicy foods, onions, cucumbers, mushrooms, things along those lines. Crackers, toast, and yogurt can help prevent gas. And then things like asparagus and broccoli can contribute to odor when your pouch is open. There is a complete list on page 1156 that you can look at. You never want to put aspirin tablets in the pouch because they can cause an ulceration of the stoma. Um, the patient who has a sigmoid colonoscopy may benefit from colostomy irrigation to regulate elimination, but most patients who have a sigmoid colostomy become regulated pretty much through diet. Resumption of normal activities. We want to encourage these patients to voice their concerns, their feelings, to get back out into normal activity. They may have a lot of a fear of being accepted by others, feeling of grief because of the body image disturbance, and then again, concerns about sexuality. Again, just encourage them to verbalize their feelings, to talk to their family, and help to maintain relationships and raise the self-esteem. And there's also a nice chart on page 1156, 56.4 that goes over trying to help that patient care for that colostomy. Mechanical obstructions. Mechanical obstructions can occur for a number of reasons, specifically a lot of times with colorectal cancer. These are two of them. The first one is called an intersusception. The second one is a volvulus. The intersusception is where there is an actual telescoping of the bowel, and you can see here where this section right here ends up going into this other section. It kind of folds on itself and it looks like a telescope. With the volvulus, you actually have a twisting, 180-degree twisting of the bowel there so that it's not functioning properly. Both of these caused the bowel to be physically blocked, and the obstruction can be partial or a complete blockage. Remember that your intestinal contents are composed of ingested food and fluids, saliva, gastric, pancreatic, biliary secretions, and of course swallowed air. In both mechanical and non-mechanical obstructions, the contents start to accumulate at and above the area of obstruction. So then the abdomen starts to get distension from the fact that the intestine can no longer absorb the contents and move down the intestinal tract. To compensate for the fact that all of your ingredients are not moving down, peristalsis tries to increase in an effort to move those intestinal contents down. This increases and stimulates more secretions, and that leads to more additional distension. The bowel then starts to become really swollen. You have increased capillary permeability. You have plasma leaking, fluid trapped in the intestinal lumen. So then you start getting fluid and electrolyte issues. You have hypovolemia, and it can lead to hypovolemic shock. And you can also, with the fluid and electrolyte imbalances, you can have a loss of gastric hydrochloride, and that can lead to metabolic alkalosis. These are two types of polyps that can occur in the colon itself. You have a sessile polyp, which tends to be a little bit smaller, and then a pedunculated. Polyps in your intestinal tract, just realize they're just small growths, and they're covered with mucosa, and they're attached to the surface of the intestine. Most polyps are benign, but they always have the potential to become malignant. So your polyps are identified by tissue type, and almost all of your colorectal cancers develop from adenoma. So you can just see from the shape of these, your pedunculated stands up a little bit more in the wall, and then your sessile is just comes a little bit off of the skin itself. Well, that is the end of the chapter, and please make sure that you read the part on colon cancer in your book. Thank you.